So Nilesh has obviously touched on the echo side, so I'm going to focus down primarily on the other imaging of pulmonary hypertension primarily. So here at Imperial, we're a relatively big tertiary referral centre for pulmonary hypertension. So I'll just show you kind of what we normally do as part of our workup for pulmonary hypertension. Hopefully that will show some relevance to all of you, because cases that come to tertiary centres don't start in tertiary centres. So the point is, you are often going to be the first line of picking up these pathologies, and obviously if you come to a tertiary centre you need to be familiar with the line of investigations and also what the tests are there for and what they're trying to show. So as Nilesh has alluded to, we define pulmonary hypertension still on invasive angiography. So despite being able to estimate the PA pressures on echo and using any other method, it's still a diagnosis that's done by cath. So the important thing to recognise is pulmonary hypertension covers the whole group of whatever the cause of elevated pulmonary pressures are, but we tend to use the term pulmonary arterial hypertension specifically for those who've got wedge pressure of less than 15 millimeters of mercury. So in other words, the left-sided pressures are normal. So this is not left heart disease that's driving right heart disease, but rather this is a primary lung or pulmonary artery problem. So that's where the confusion can arise in terms of where people use the definitions. Okay, so if you look at the latest guidelines, they divide up the pulmonary hypertension group into a series of classifications. This is actually quite helpful because it kind of underscores the value and the reason why we do certain imaging techniques. Part of the reason why you categorize them in this sort of big group is it helps you gain some information about prognosis, but also determine treatments. Obviously, one of the major groups, but only about 20% of cases, is the thromboembolic disease, the chronic thromboembolic disease. So it's vital that you identify that group because the treatment is totally different. So whereas the treatment for a lot of pulmonary arterial hypertension cases is just medication and effectively supportive, if they've got substantial embolic phenomena, if they've had substantial thrombus, then there's potentially a surgical option, which is potentially curative. So it's important that you identify that group, if for no other reason than for that reason. So you can see here pulmonary arterial hypertension is in this group by itself, and within that they include things like portal hypertension, where you get weird shunting, some drugs, and also the idiopathic pulmonary arterial hypertension, which is what most people think of. There's also a group, the pulmonary Veno-occlusive Disease and pulmonary capillary hemangiomatosis. So that's primarily going to be a radiological diagnosis. So I'll show you kind of what you look for on CT for that. Obviously, one of the biggest groups is going to be pulmonary hypertension driven by left heart disease, and that's where the wedge comes in helpfully, as well as echo. Obviously, lung disease, generally abnormal lungs, and hypoxia can predispose to it. And there's also other multifactorial mechanisms which kind of nobody really understands the full mechanism behind the pulmonary arterial hypertension. So what do we do in terms of imaging? Obviously, you've heard about echo, and echo's got a very important role in identifying patients with pulmonary arterial hypertension. It can identify surrogately pulmonary pressures, but also it can give you some information about the right heart. There's still an important role for pulmonary, for plain radiology, simply because you will often be the first person to notice that the pulmonary artery looks big, and that can trigger a whole line of investigations. You know, it's not uncommon to get breathless query cause, GP film even, and you'll notice that the pulmonary artery looks big, and then you'll suggest some further investigations. Nuclear medicine I'll explain, primarily as a VQ scan. CT, primarily as a CTPA, but also as an HRCT or looking at the lungs. Ultrasound, you're using it usually just to identify patients with portal hypertension. So you're looking at the liver, you're looking at the portal vein, identifying flow in the portal vein. MR has got a newish role, and not everybody uses MR. So MR is quite popular in this country, specifically MRA, because the surgeons in the UK are happy to operate off two non-invasive modalities such as CT and MR, as long as they both agree. So if you see disease on a CTPA and that's confirmed on MR, the surgeons in England, not even in Scotland, are happy to operate just off that information, whereas in Europe it's still, patients are still referred on for invasive angiography, as in Scotland in fact. And obviously pulmonary angiography as a kind of corollary to that. Okay, so what do we look for on a plain film? Well, ideally, we try to confirm whether there are some changes of pulmonary hypertension. It will give you some idea as to the potential etiology. Obviously, you're looking at the lungs. You can monitor the condition, have a look at the lungs, how they changed, look at the pulmonary artery size, and also, obviously, in acute deterioration, you're looking for other explanations for why patients suddenly go off. So it's a very important investigation in our kind of imaging armory. So these are kind of quite extreme. So here you can see normal chest x-ray, pulmonary arteries within normal limits. Remember, when you're looking at a frontal chest radiograph, you'll see the pulmonary trunk here, and then you'll see the pulmonary arteries. And you can see, usually you see the lower pulmonary arteries, you don't see the upper so well because the blood flow is dependent. So you know if you do a supine film, often you'll see plethora in the upper lobes, and that's just a manifestation of the fact that blood flow is dependent in the lungs. Obviously, this is an extreme case, but you can see the pulmonary trunk is quite large, and obviously both pulmonary arteries are very big. You could sometimes be caught out thinking it's lymphadenopathy. Sometimes it can be that gross. Okay, so normal or abnormal? So they've had a stenotomy. It's okay. Normal or abnormal? It's going to be usually abnormal if somebody shows you it in a slide, isn't it? It's a bit boring showing you a normal film. But do you see, like, the pulmonary trunk here looks a little bit prominent? And even the pulmonary arteries here are a little bit on the big side. Sometimes you can actually see prominent pulmonary arteries, especially in young people, and that's a kind of, it's difficult to get your eye in. And sometimes if you're not sure, you can maybe err on the slightly side of caution and recommend an echo as an indirect way of looking at the right heart and making sure that all looks normal. Because obviously the difficulty is, you know, we're just faced with a chest radiograph. We don't have any other information often other than shortness of breath, so it makes it a bit tricky. I know Nilesh always blames me for saying clinical correlation, but unfortunately, you know, we're not looking at the x-rays, we've got to look at the patient. Okay, so you can see obviously this is abnormal lungs, and you can try to identify whether it's an interstitial pattern or an airspace pattern, as Karen's kind of talked to you a little bit about earlier. So in terms of the VQ, what you have to remember is VQ is reported in terms of probability, okay? So it's not an absolute positive, negative. It's all about probability. So it's low, intermediate, or high. We like to think, yes, high probability equals PE, low probability equals no PE, but you can get caught out and there's certain catches. What you're looking for is you're comparing the ventilation part, which is this part, usually on the bottom at the imperial images, and you can identify that this is the ventilation because you can actually see the trachea takes up the tracer that you're breathing in, and you compare it with the perfusion bit. And what you do is you look at the lungs, AP, and then posterior to anterior, so the exact mirror opposite, and then you look at these obliques, and these obliques are basically the equivalent of lateral chest radiographs, and it just allows you to throw off the various lobes that would otherwise be superimposed one on the other in the AP. And all you do is simply compare it with the imaging below and see if there are any defects. You can get, if you use the pipette criteria, normally you need more than 2 mismatched areas to call it high probability. One mismatch is an intermediate probability by pipette, so it can be relatively insensitive at times. So you could have actually had a PE, but you know, if you're going to follow the strict criteria, you may have to report it as an intermediate probability. So you just need to be aware again of the limitations. So what do you think of this? Okay, so we're looking at the ventilation. Ventilation looks on the whole pretty good, doesn't it? Yep. Whereas the perfusion is quite mottled, quite abnormal. So obviously there are area of mismatch. There's multiple areas, bilateral. This is a high probability scan. Agreed? Okay, another high probability. Little bit more tricky here because the ventilation's not normal. And again, what you have to do is try to, in your mind's eye, subtract the areas that are matched and compare it with the areas that are not matched. You've got to be a little bit careful also because you can get clumping of the tracer, which can also cause problems with interpretation. Okay, so VQ can be very helpful because if you have very peripheral emboli, you will not be able to detect those easily on CT. So in some cases, actually a VQ is a superior test to a CTPA, although if you look at the British Thoracic Guidelines, usually if you're querying PE, first line of investigation is still CTPA. But you have to be aware that in this particular group, CTPA by itself is not the best way of excluding thromboembolic disease. And going back, it's actually quite helpful to identify those with thromboembolic disease because the treatments are potentially different. So that's why it's important. Saying that, if you've got only subsegmental disease, you're not an operative candidate anyway, because you basically can only operate on the peripheral, maybe the segmental vessels, but certainly not subsegmental vessels easily. And usually, even if you do try to operate on those cases, they don't have a good surgical outcome. Sometimes what you see in pulmonary arterial hypertension, just idiopathic, is you actually see a paucity of tracer in the upper lobes, and that can sometimes be a catch if you're not used to seeing that. Okay, so just a couple more examples. So again, what you're looking for is mismatch. So there's a big differential for mismatch. Obviously thrombus is in there, but you need to think about weird things like tumours that can give you a similar appearance. Mediastinal disease, especially like fibrosing mediastinitis, and also even aortitis. So the key is, just because it's a positive VQ doesn't always mean it's thromboembolic, but certainly that's the most likely thing. But you may still need to go on to do a CT, even though you've confirmed a PE or what you think is a PE based on the VQ. The other thing to say is it can often underestimate the extent of proximal disease. Remember, not all thrombus is occlusive thrombus, and what you're relying on the VQ is that tracer not getting through. So if it's non-occlusive, tracer will still get through, it will still be picked up on your camera, and it will look as if you may not have a defect. So you can actually underestimate quite substantial proximal disease. Were you going to ask a question?
What is aortitis?
So I think it's just a general inflammatory condition, and you can get pruning of the pulmonary arteries as part of that. So you can get a Takayasu's type phenomena within the pulmonary arteries, although it's rare. Usually it's things like Behçet's that tend to affect the pulmonary arteries more than Takayasu's, but all part of a vasculitis rather than a pure aortitis.
Only vascular problem, but the etiology.
Yeah. Okay, so again, kind of, you can see a paucity of tracer in the upper lobes. Here you can see the ventilation is actually worse than the perfusion. Yep. So you may say this is parenchymal disease rather than thromboembolic. So this is just to emphasize the fact that you can get non-occlusive thrombus quite easily, and this is not an uncommon feature of especially chronic PE. Remember, acute pulmonary emboli, it's a bit like an acute STEMI, often occludes the vessel. If not the segmental, then the subsegmental vessels might be associated with an infarct, all of that. But as you go over time, you can get recanalization, you can get opening up of other vessels to compensate, so you can get prominent bronchial arteries, for example, prominent intercostals, all of these things compensating for those stenoses. But the key is here, this is non-occlusive, this is a web in the vessel which is also non-occlusive. If you do a VQ scan, you won't see these. You won't even appreciate them because they're non-occlusive. And yet this can cause pulmonary arterial hypertension, and also it's potentially surgically correctable. So that's why it's really important. Okay, so there are other congenital anomalies that you need to keep an eye out for. I've already mentioned the anomalous pulmonary venous drainage. Do you remember which is the commonest anomalous pulmonary venous drainage? Just the right upper lobe pulmonary venous drainage, and you look to see if anything joins into the SVC. So here you can see the SVC. Obviously the pulmonary arteries are big, and you can see there's a vessel draining into the SVC here. So that's anomalous venous drainage. What's it associated with? Sinus venosus defect, yeah? So traditionally the superior sinus venosus defect, and this is what you're seeing here. So remember, ASDs, unlike VSDs, cause right heart dilatation. VSDs, usually the majority of VSDs are in the perimembranous portion of the septum. Next time we'll get onto the CT, have a look at the relationship of the perimembranous septum to the outflow tract, the pulmonary outflow tract. So the reason why VSDs traditionally don't cause first chamber dilatation as the right heart, but rather the left heart, is because the flow bypasses the right heart, goes straight into the pulmonary arteries, causes enlargement of the pulmonary arteries and back into the left side. So the left sides get bigger before the right side, whereas in ASD, it goes via a shunt between the atrium to the atria and then into the ventricle. So easy peasy, if you're ever faced with a dilated right heart on CT, on MR, on echo even, you have to think about four things. This is irrespective of things like thromboembolic disease, lung disease, left heart disease, okay? So you think about, what, ASD? What type of ASDs are there? Okay, so we said primum, you look for secundum, which is more common, and then the other weird ASDs like sinus venosus. Sinus venosus can be superior or inferior. Superior involves the SVC, inferior involves the IVC, and then also quite rare, is the deroofed coronary sinus, yeah? Because effectively that's forming a connection between the left atrium and the right atrium just via a different connection. So you always think about ASDs. If you mention sinus venosus, you need to think about anomalous venous drainage, okay? About 70% of these two conditions coexist. So if you've got one, you must always look for the other. So just check your pulmonary veins. And then what you can do is then you obviously look at the pulmonary artery. Is the pulmonary artery big? That will give you some clues as to whether it's pulmonary arterial hypertension. And then you may think about, obviously, if the PA is normal, the right heart's big, then you can start thinking about primary right ventricular cardiomyopathies like ARVC. Okay? But in general, if you're reporting a CT, you see a dilated right heart, lungs, PA, no PE, okay, am I missing an ASD? Am I missing anomalous venous drainage? Okay, so just have that system in your head. Okay, so the role of CTPA. Obviously, it's fantastic at looking at pulmonary arteries, especially the large vessels. We also get a heads up on the mediastinal structures, and we can also look at the lung parenchyma. Remember what I mentioned, you can obviously reconstruct at thinner cuts than a standard HRCT. People often prefer still HRCTs just because of the image, the contrast to noise ratio is a little bit better because you're using the sequential scanning rather than the helical scan. CTPA is still helix, unless you've got the 320 where you could potentially do it as a sequential scan. But it's because you need to chase the bolus, you often do it as a CTPA. So what you look for on the CTPA, in addition to looking for pulmonary arteries, is obviously the ratio of the pulmonary artery to the aorta. So if you've got a ratio of greater than 1, so in other words the pulmonary artery is the same size if not bigger than the aorta, then you've got a high probability of you having pulmonary hypertension. So notice you say pulmonary hypertension, not pulmonary arterial hypertension, because you may not necessarily be able to tell whether it's left heart disease. Obviously, if the left atrium is very big, you might steer or report more towards left heart disease, but you can get normal-sized left chambers and still have left heart disease and driving pulmonary arterial hypertension. So just be aware of that. The other thing that you can look for is the absolute measurements, and what you do is you just measure AP. Okay, so this is the main pulmonary artery. That should be anything between 30 to about 32, maybe even 33 millimeters. I tend to use 30 because it's easier for me to remember. And the left and right should be about 22, 23, that sort of thing. Okay, so if they're bigger than that, there's a chance they may have pulmonary hypertension. I normally say, if I'm not sure, get an echo next and take it from there. Yeah, because often they will have some TR, and you will be able to get some sort of indirect measure of pulmonary arterial pressures, and then obviously that then instigates a whole line of investigation.
What happens to measure it?
So just where you see it clearly, so there's no strict level, it's just off the axial image, so you just scroll up to where you see it nicely like that and just measure it AP. The key is just going AP. Yeah. So again, here's an example, massive pulmonary artery clearly. Yeah. So if you see that, again, no PE, lungs look okay, just run through that checklist, ASD, anomalous venous drainage, if nothing else. Okay, pulmonary arteries can get absolutely massive, okay? So, you know, you'd be surprised at some of the pulmonary arterial hypertension cases. I think one lady has got something like a 9 or a 10 centimeter pulmonary artery, so they're massive. The weird thing about pulmonary arteries are, as they dilate to that extent, you can actually get dissection of the pulmonary arteries, which is extremely rare. So it's usually only in these sorts of cases that you'll ever see that. But that can, unfortunately, be a cause of sudden deterioration. And the problem is we're not necessarily switched on to looking for dissection of the pulmonary arteries because you just don't recognize it as a normal phenomena. But you just need to be aware in that group, you do have to be a little bit careful. Although the treatment's conservative, it's not like you're going to operate on them. But nevertheless, it explains why people may suddenly deteriorate. The other thing is, as the pulmonary arteries get very big, they can often calcify. So if you think about it, you see calcification in the aorta all the time. You'll never see calcification in the pulmonary arteries unless they're abnormal for whatever reason. And as the pulmonary arteries get big, not only do they calcify, they can also form thrombus in situ. So just because you see laminar thrombus in a pulmonary artery, it doesn't necessarily mean that that is the cause of the pulmonary hypertension. Rather, it can be thrombus in situ. And the key to that is often it's associated with calcification as well. So that's just a phenomena of poor flow around the pulmonary arteries rather than the other way around. So it's, again, another potential catch. So again, you're looking at the right heart, you'll look for right heart hypertrophy, you can look for septal flattening, as Taryn's already shown you. So looking at the lung parenchyma, what we traditionally look for is this thing called mosaic attenuation. Okay, so you know that we see this not infrequently in radiology, and often the dilemma is, well, is it air trapping? Is it not air trapping? What's the etiology? Is it the black lung that's normal or the white lung that's abnormal, or vice versa? So what you're supposed to do if you see mosaic attenuation is first think to yourself, is the vascularity normal? Okay, so if the vascularity looks normal, then it's not going to be secondary to chronic thromboembolic disease, or less likely due to chronic thromboembolic disease. What you can see here is the vascularity in the whitish lung is more than the vascularity in the blackish lung. So in other words, what you're seeing is purely a manifestation of almost like a VQ scan, because you're seeing lung perfusion, right? So that's what this is a representation of. Obviously in air trapping you would see that, but the vascularity would be normal. Then you have to do your expiration film. So if you've got air trapping, the black lung stays black. Yep, because it's trapped, the air is trapped in there. It doesn't expire when you get them to breathe out. So again, kind of examples of mosaic attenuation. And it can be relatively subtle. Okay, so the things that you're looking specifically for, especially in our clinics where we get them referred and they're being worked up for pulmonary arterial hypertension, is obviously looking to see if there are any webs or stenoses or areas that would prompt you to say this is actually chronic thromboembolic disease. You might also see peripheral opacities and scars. Remember, a lot of these patients who've had big PEs in the past can have infarcts previously, and that can manifest itself still as residual consolidation or scarring. You might also get the mediastinal collaterals. Remember, when patients like this present with hemoptysis, often the vessel that they end up embolizing are the bronchial arteries, and that's because you get bronchial artery hypertrophy. So they don't tend to find the vessel that's bleeding within the lungs in these sorts of patients, because it's usually the bronchioles that cause the problem. So again, you can see filling defect nicely. You've all seen an example of that. So that's ideally what you're looking for in acute pulmonary emboli. So again, filling defects, agreed? Okay, so here's an example of thrombus in situ. So massive pulmonary artery, lots of calcification and thrombus lining that area of calcification. Okay, so it's a catch, because sometimes it can be tricky to tell the difference sometimes. And you know, especially if a patient's suddenly gone off, they may say, well, have they had a PE even though they've not had PEs in the past? You know, you can still have a PE. So it can be a dilemma on imaging. And I'm constantly asked, do you think this is an acute PE or do you think this is chronic PE? And to be honest, I struggle. You read the papers, they say measure the Hansfield unit. If it's not in the center of the vessel, it's more likely to be chronic. If it's collateralized, if it's opened up, it's more likely to be chronic. All of these are rules of thumb. I don't think you can say 100% one way or the other. That's the problem. So often the safest thing to do is assume it's acute, anticoagulate, and then re-image. Okay? So this is just showing the thrombus in situ. Okay, so the other things you can look for are the collaterals, as we've said. Obviously, in this case, they've got pericardial and a pleural effusion. This is an example of a web in the vessel. So what you're doing is you're looking for these straight lines. You sometimes see an abrupt caliber change as well. And obviously, you can sometimes see a complete vessel cut off. So this is often appreciated better if you MIP up your image and look especially in the coronal plane, because you'll see kind of big gaps. And what you can do is you can use the mosaic attenuation as a way of kind of helping you identify where you think there's a problem. Because remember, your mosaic attenuation is just kind of your VQ scan, as it were. Sometimes it's useful also to cross-reference with a VQ if they've had a VQ, because again, that kind of gives you a bit more diagnostic confidence. Okay, so do you see here, you kind of get this very abnormal, very twisted vessel, and that's basically where you've had thrombus, it's partly recanalized, got a little bit better, but forms scarring and fibrous tissue, and it scars, and it just distorts the vessel and twists the vessel. So what the surgeon does is he kind of sticks in a probe and picks away at it. I remember watching it, and somebody puts their hand up and says, do you really think this is surgery? This is like nose picking. And the surgeon was like, yeah, you're right, and it's just as satisfying. So it's exactly the same thing. It's a bit boring. And the interesting thing is I think people have shown that the left lung does better than the right lung. I think it's that way around. And people are not sure if it's because the surgeon always starts with the left and then gets a bit bored by the time he gets to the right, because it's so long. It's like 4 or 5 hours, and it's just like constantly picking away. So it can be a bit boring. But anyway, there you go. So the other things that you're looking for are, as we said, bronchial artery hypertrophy. Remember, blood supply to the lung doesn't just come from the pulmonary arteries. There is some vascularity coming from the bronchioles and the intercostals. Okay, and obviously, if you occlude the pulmonary arteries, those vessels have to accommodate more. And again, these are just more examples of that. So lung disease, what do you think the diagnosis is here? Looks like emphysema, yeah, so quite common. What do you think the diagnosis is here? Emphysema also? Okay, cystic lung disease, yeah? Multiple cysts. So you know in radiology it opens up your big differential of histiocytosis. What else? There's a classic four. So histiocytosis, LAM in women, and then things like tuberous sclerosis and neurofibromatosis, and those were with preserved lung volumes, yeah? Okay, so why do both? As we've already said, VQ can actually be a bit more sensitive, but it's often useful to have the two. The point is your CTPA, especially you've seen if you have a patient who's very breathless, who's breathed a little bit, you can be very uncertain as to the peripheral vessels. So the VQ can give you that added little bit of confidence. So there's still an important role in VQ studies, especially if you've got somebody with a history of PE in the past and you're working them up for pulmonary arterial hypertension. Okay, so this is just basically emphasizing the fact here. So dilated right heart, you've all seen, so you guys know what that looks like. The important thing is VQ has a superior sensitivity compared to CT, as we've said. So MRI, as I've said, not everybody uses MRI, but MRI can be very useful in the assessment of the right ventricle. We can also assess flows. So one of the ways that you can assess to see if there's a shunt, remember some of these cases with pulmonary arterial hypertension will have shunts as the mechanism behind the pulmonary arterial hypertension. Not just sinus venosus defect, but things like that. And you can estimate the QP-QS, okay? So you can measure the flow in the aorta, you can measure the flow in the pulmonary arteries, either the main or indeed the left and the right. And then basically you use that Q-flow technique where you measure flow through the plane and you do an area under the curve, and that gives you the volume of blood that's going through that vessel. And then you can compare the volume of blood in the right versus the volume of blood in the left. Obviously they should be about the same. There's always going to be a little bit of error, so you kind of have to kind of take that into account. And remember, you can get things like balanced shunts, where if the pulmonary hypertension has been that long-standing, you may have started off with a kind of left to right shunt, but then that can equalize and then finally reverse when you get Eisenmenger's physiology. But it's a useful way of kind of estimating, you know, if you've got an ASD, to see what the QP-QS is. You can do it all non-invasively with MRI, so that's very helpful. Okay, so where we use it, we combine it with our CTPAs, also because it gives us a bit more confidence as to the peripheral vessels using the angio bit. So here's an example. Here's a CT where you can see the vessels totally occluded here, and this is the equivalent MRA image. So they're as good, if not better, I would say. And obviously it takes a little bit of training for your radiographers, but what you're hopefully trying to demonstrate is that there are filling defects which match the CT, and basically therefore you've got two independent modalities both telling you the same things, and the guys at Papworth say that's enough for them to operate, so they don't need an invasive angiogram. So before we started doing MR, everybody with a positive CTPA or a VQ had to have an angio, so there was loads of angios that they were doing. Now it's all been superseded by MR. There's still a role for angio, because obviously not everybody will tolerate an MRI. You get people who breathe, and you end up with non-diagnostic CT and MRA, and the VQ is positive. And in those sorts of cases, you still have to go on to do angiography. But you know, the role of angiography in diagnosing thromboembolic disease, certainly in England, is reducing. So it's quite useful to get familiar with it. Okay, so this shows you after surgery you can monitor treatment. Do you see here there's a web there? Do you see here these vessels are all cut off? Yep, and this is post-surgical, so nice result. You can see that that web's gone. Some of those peripheral occlusions have got better, and the PA's concomitantly gone down in size. Again, another web there, another web there, got a little bit better. So angiography, just showing you the same thing. And you can use this to help with your surgical planning. So often the surgeons want us to produce these three-dimensional MIPs, so they don't just want the axial image, they want to be able to rotate it around. You can do that nicely on MRA, because like CT, it then becomes a volume acquisition. So one of the reasons why we do MRA with gadolinium is because you can acquire your data quickly. Okay, so that means you can acquire big volumes quickly. Normally, to acquire a volume of data on MR, would require, you know, thinking about your coronaries, if you do coronary MRA, that will take up to 15, 20, 25 minutes to acquire that. Nobody's going to hold their breath for that long, so you have to then use this navigating method to track breathing to acquire your data at a particular breathing point. With gadolinium, because it causes such marked T1 shortening, you can build on that and use that to basically give you the contrast to noise resolution that you wouldn't normally have. So that's why you can acquire a volume, and that allows you to do all the reconstructions. Okay, so you can also see collaterals in the same way as you would on CT. So here's loads of intercostal collaterals. You can also look for pulmonary vein stenosis. The important thing about pulmonary vein stenosis is it can actually mimic pulmonary emboli. So patients can present with breathlessness. You can do a VQ study, and that actually shows you a perfusion defect on the VQ, and that's basically a manifestation of the problem with the pulmonary veins. So MR, when you do an MRA, you can follow it with a second phase and just do an MRV. So you get that for free, and you can look at the pulmonary veins. And it's also helpful to identify things like PDAs, which are quite easy to miss. Yeah, because PDAs, if you think about it on the axial image, you're basically imaging through the plane of where the connection is, so it's really easy to miss. So that's why you've got to look in these different planes. Okay, so anomalous venous drainage, you guys are all the masters of anomalous venous drainage. So you know that on the left upper lobe must join into the brachiocephalic vein. Brachiocephalic vein comes down and eventually makes its way back into the RA. Okay, and here you can see that there's your SVC. Do you see all these vessels draining into the SVC? So this is of the right upper lobe, and this is what we would describe as scimitar syndrome. Yeah. So all the venous drainage of the upper and the lower lobes via this big collateral vessel, which then joins into the IVC. Yeah. So the point is they all have to make their way back into the right heart, and they do that by the quickest route. So remember, brachiocephalic, SVC, IVC, coronary sinus. Okay. Okay, so you can actually measure the extent of septal flattening, and people have used that as an indirect way of trying to estimate pulmonary arterial pressures. It's a bit of a hit and miss affair, to be honest, but you can certainly see the D-shaped ventricle, you can certainly see septal flattening and bowing. Okay, so the mechanism is supposed to be you can resolve septal flattening into diastolic septal flattening or systolic septal flattening. Okay, in diastole, that's traditionally a volume problem, whereas in systole, it's traditionally a pressure problem. So if you think about it, if the right ventricle is dilated, it gets bigger, the pressure builds up in diastole, and then that causes septal flattening in diastole. For it to exceed the pressure of the left ventricle in systole, the right pressure must be really high. So pressure versus volume loaded RV. So that can be a helpful way to distinguish the two. Obviously, if the RV is dilated, then that helps as well. So this is just another example of the sinus venosus defect. And this is just using velocity encoding, the Q flow that we mentioned. Here, all you're doing is you're just trying to emphasize the fact that there's flow going across this sinus venosus defect. So again, QPQS, you end up with these flow curves. You do area under the curve, you can estimate your pulmonary flow, you can estimate your aortic flow. So it's quite a nice way of also looking for inadvertent shunts that you may have missed, and then go back and look for things like that. So it's quite a good fail-safe. So there's important things to say. The commonest shunts that we'll see other than ASD are obviously the sinus venosus defects with anomalous venous drainage. But remember, it's not uncommon to see bronchopulmonary shunting. What we mean by that is because the pulmonary arteries are occluded effectively, a lot of the blood is getting to the lungs via the bronchial arteries. The bronchial arteries then have to feed back into the pulmonary veins, because that's a normal drainage system of the lungs, which then makes it back into the left atrium and to the left heart. So that blood effectively stays on the left side, never makes it onto the right side. Whereas anomalous venous drainage is the exact opposite. So you've got, instead of pulmonary vein drainage going back into the left heart, it drains back into the right, so that stays in the right circulation. So they're equal and opposite if you think about it. Okay, and that can be quite helpful. Obviously things like PDAs can catch you out and stuff like that. But what you're looking at is you want the RV volumes to match the PA flow, because then you know that whatever's getting into the right heart is coming out of the pulmonary arteries. And similarly, you want the LV volume to match the aortic flow. And ideally, all of those should be balanced. So by using QPQS, by looking at the RV stroke volume, the LV stroke volume, you can roughly work out where a shunt's going to be just by kind of drawing out a matrix and thinking, okay, where is there a connection? And that can be quite a helpful thing to do. Again, you can also do tissue characterization. Again, the role of this is a little bit limited, and we tend not to offer it routinely. You'll see this non-specific RV insertion point fibrosis that we've seen on numerous occasions. It's said to be a marker of poor prognostic outcome compared to normal other cases without. With regards to angiography, it used to be identifying thromboembolic disease pre-surgery. It still is in Europe and in the US. It will show you the same things that we've outlined. The important thing is it can be helpful because it gives you a bit of information about parenchymal staining. So again, it's like a VQ scan in that sense. But also, obviously, when you've got a catheter in there, if you need to biopsy anything, you can do that. And when do you biopsy things? When things don't look quite right. So unusual causes of pulmonary hypertension. Let's have a look at this. What would you say on this VQ scan? Positive, negative, normal. Is it normal? Okay, so let's look now. Ventilation part looks all right. Bit patchy here, agreed? Okay, where's all the perfusion here? Where's all the perfusion here? Remember, all you're doing with this is you're looking at the patient this way, then you're looking at the lungs the other way, right? So this is anterior, this is posterior, just AP, PA or whatever, okay? And then these are obliques, where you're showing the left lung, LPO, and the right lung as an oblique. Because what you're trying to do is throw off the fact that there's the middle lobe and the lingular, because all of those are superimposed. Exactly the same principle as doing a lateral chest radiograph, as opposed to just doing a frontal chest radiograph. And you're just trying to identify where you get defects. But can you agree there are multiple areas of mismatch? So this would be reported as a high probability VQ scan, right? So we can say, yeah, high probability thromboembolic disease, thank you very much. Okay, so now we do a CT, oh my God. Is this really a PE? There's definitely filling defect within the main pulmonary arteries. But what do you notice about the pulmonary arteries that are a little bit odd here?
Enlarged.
Yeah, so pulmonary trunk's definitely enlarged, but that could be because of the pulmonary emboli. But you don't normally get pulmonary arteries that look that big and look a bit expanded. So that's not normal in clot. Yeah? So now you have to start thinking, okay, if it's not clot, what else could it be? So some sort of filling defect. What could it be? What's your differential for this appearance? Yeah, so tumour, so specifically in young people as well, you think about sarcoma, but you can get disseminated intravascular metastases as well. So again, here, MR can be helpful, can give you a little bit of information about tissue characterization. Personally, I find it a bit hit and miss. But a PET scan can be very helpful because it will show that that area is metabolically active. So again, pushing you towards tumour thrombus. And this was a case of pulmonary arterial sarcoma. Obviously, in that sort of case, you still need angiography to give you tissue to diagnose it. Okay, but on the imaging, you're looking for filling defects that expand the vessels, that maybe have enhancement with contrast, that don't resolve with satisfactory anticoagulation. Sometimes it can be very difficult to tell, and you end up repeating the imaging a couple of months later after anticoagulation. If it's getting worse, if it looks not getting any better, then that might trigger another line of investigation. Okay, next case. What do you think this is? Filling defect within the pulmonary artery. What is it? Pulmonary emboli, maybe, might be, could be. Hang on, what's that? Where is that? It's in the RV. It could still be all thrombus, clearly. But hang on, if we follow it through, that's a bit weird. It's going into the RA, isn't it? So it could still all be thrombus. It could be massive thrombus. Hang on, it's in the IVC. So what do we think this could be? Yeah, renal carcinoma is the first thing to exclude, but the kidneys look normal, at least the bits that we've got. So I'll give you a clue, it's a lady, and as we scan down, you can still see something in the IVC. Not sure what that is. What the hell is that? So what is it? Classic case? Intravascular myomatosis. So it's one of the classic differentials for something growing up the IVC into the right heart, and that can embolize and cause pulmonary emboli. Okay, even if they've had a hysterectomy, you can still get this. Unfortunately, it's extremely rare, but it's just useful to have in your differential, especially for those of you who are doing echo MR, you know, for masses invading into the IVC. Especially, obviously, if it's a woman, you wouldn't necessarily venture it if they're a bloke unless they went to transgender reassignment. Okay, next case. Okay, based on that VQ, would you say low probability, high probability, intermediate probability? So the ventilation is not normal, which is always going to make it a bit more tricky. So now what you have to do is try to identify whether there are areas of mismatch or not. I think most of these are matched, but there probably is one or if not two areas.
I mean, it's not a great deal.
Say again?
It's not mismatched, but not a great deal.
Yeah, I mean, that's the point. It's mostly matched. So you'd probably be erring on the side of saying this is an intermediate probability, because there's probably at least one area that isn't matched. So on the pipette criteria, you'd then have to say, hang on, this is intermediate probability. So not that much help, really, because it's not really giving you a yes-no answer, which is what we want. So you might go on to do more scanning. So this was a case of fibrosing mediastinitis, which you can sometimes see as idiopathic. It's a bit synonymous to retroperitoneal fibrosis. But also you can get it in things like sarcoid. Okay, so you have to think about these sorts of things. And basically you get an inflammatory response in the mediastinum, and that pinches off vessels and it causes narrowing. And the reason why it's important to make that diagnosis is you can identify it on cath, and then you can angioplasty these things and they get better. So you can actually treat them non-invasively. But again, it's kind of quite far the diagnostic pathway. Okay, final case. Okay. Not final case. This is just an example of veno-occlusive disease. What you look for in veno-occlusive disease, apart from the mosaic attenuation, is interlobular septal thickening. It's a disaster, isn't it? Because what else gives you ground glass and interlobular septal thickening? Yeah, lymphangitis, but more specifically that we see loads of times, pulmonary edema. So this diagnosis often can be quite difficult on imaging alone, and often you have to combine it with a cath. So if they've had a cath and they say to you they've had an echo, they've got normal LV, they've had a cath, the LV, the left ventricle pressures are normal, so they're saying to you, look, we don't think this is left heart disease, and you're seeing features that look like pulmonary edema, you must think veno-occlusive disease. And the reason why that's important is it renders them resistant to a lot of the treatments, and you can actually make them worse by giving them standard vasodilators. So it's quite important to get the diagnosis from that point of view. Okay, so again, interlobular septal thickening. Sometimes you can even see nodules. It can be quite tricky. But this is what we mean by interlobular septal thickening for the cardiologist. So it looks like street paving. Okay, and sometimes when it's associated with ground glass, we think of crazy paving, but that tends to open up a big differential for radiologists. When we say crazy paving, we mean primary alveolar proteinosis, which is another condition. So this is the kind of mosaic attenuation. So you dismiss this as chronic thromboembolic disease. This was actually veno-occlusive disease. So it can mimic primary pulmonary arterial hypertension, which makes it a bit tricky. So sometimes these patients end up having biopsies. Okay, last case, definitely. What is wrong with this VQ scan? So this is the perfusion part of the VQ scan. What do you see on this image that you haven't seen on the other images? Say again? Yeah, you can see the kidneys. Okay, talk to me. How does perfusion work? So you inject it into the vein, it then goes into the lungs and gets filtered out by the lungs, doesn't it? The lungs is a barrier, so nothing should get into the left side, therefore. So why is it getting into the left side? There must be a shunt. So if you see this, you have to start thinking, is there a shunt somewhere? And this may be your first clue on a VQ. Okay? So in this case, this was a case of somebody with portal hypertension. So basically you can see there's loads of collaterals here, spleen's a bit big, but the liver was actually normal. And this was somebody with hepatopulmonary syndrome, but that's another story. But the point is portal hypertension can give you shunting. But obviously equally, if you had a sinus venosus, all of these things that can cause shunting, you might see that first on a VQ scan. Okay, we'll call it quits there, I think. Okay, so the last thing to say is imaging is really, really important in patients with breathlessness, and you've got the whole gambit of imaging from echo to chest radiograph to CT to MR to even angiography, and you have to basically think your way while you're doing certain things in a certain order. But the most important thing, certainly for radiologists, is if you see a dilated right heart, it doesn't fit with what else you're seeing, just think about shunts, think about weird things like pulmonary arterial hypertension.